welcome to the webinar. This is Sharon Terry from Genetic Alliance, and we're delighted to have you all with us today. This webinar is part of our series called Managing the Massive Measures, Real People's Real Data Made Useful. Today we're going to hear from Ken Mandl from the Harvard Medical School on SMART, Building the App Store for Health. I love co-opting the point of care for a learning healthcare system. Before we get started, I just want to remind you that you may ask questions at any time during this webinar. You are muted because there are too many of you to be able to speak, but you can just in the chat, in the question box, which is in your GoToWebinar control panel, typically shows up on the right-hand side of your screen. You can type a question in at any time during the webinar, and we will tee those up for Ken to answer after he finishes formal presentation. We also want to remind you that the slides are available using the link in the chat box. So if you look in the chat box on that control panel, you'll see a link that Jeff has put there with the link to the slides. So you can get the slides and look at them as well. Obviously, they will be shown on your screen if you are using the webinar software. The recording and the slides are available within 1 week, as are all of the presentations that we have done so far in this series, which have been quite a good number. And we also have some more coming up, and we'll talk about those after the presentation. So without further ado, we're going to turn the controls over to Ken, and he will tell us about SMART. Ken?
Good afternoon, everyone, and thank you for eating your lunch over this presentation. And I look forward to the discussion portion of this as well, and I'll leave plenty of time for that. You know, the healthcare system doesn't work very well in the United States. We have the most expensive healthcare system in the world by a very large margin, with only middling outcomes. And one of the problems that we have is that we don't learn from the patients that we treat and refine our knowledge as we take care forward. This leads to poor outcomes and expensive care. And so the question is, how do we learn from all the patients all the time? And specifically, instead of some of the patients all of the time. And I'll point out that you know, even in a place like where I work here in Boston, where we have enormous amounts of academic medicine going on per square inch, the number of patients on research protocols is probably well under 2%. You know, most patients were not really capturing their information in a way that improves the care for future patients. So how do we learn from all the patients all the time instead of some of the patients all the time, or really just a couple of the patients not that often? That's the question in the learning healthcare system. Now, the federal government has invested $48 billion in health IT adoption. Mass General and Brigham form an organization called Partners that has a couple other hospitals in it. They just spent $1.4 billion to purchase Epic. That's a lot of money. If you look at those kinds of costs invested by the private sector on top of this federal investment, which is really just the tip of the iceberg, you're looking, I think, at north of $500 billion being invested in health information technology systems, and this is really an issue. A talk that I saw that I found pretty entertaining began with the phrase 1987 called and they want their EHR back. And the problem is that the $48 billion, and in fact the north of $1 trillion investment, a lot of it is in some very old-fashioned technologies that were designed in the 80s and 90s and that have kind of been built on since. They were designed as billing systems and now got things like order entry added on and documentation, but they turn out to be very inflexible for the kinds of things we need to do at the point of care. So there's a well-known curve called the Gartner hype curve that shows us that when a technology is introduced, the technology trigger, there's often a peak of inflated expectations. And that's really where the $48 billion got spent. And then there's, as you actually try to use the technology, there's a trough of disillusionment. And then one begins to make their way back towards this plateau of productivity. We're pretty close to the bottom now. But there are actually, I think, in terms of, as I talk to my colleagues about how EHR implementations are going all over the country, it tends to be actually interfering with a lot of other opportunities. And it's time to start working back towards a plateau of productivity. So let me give you an example of a problem in healthcare that is actually made a bit worse so far by our investment in electronic medical records. Let's take a very innovative company. This company is made up. We made it up for our grant application. Medtastic is a well-funded new company which has developed an elegant medication list application that has physician and consumer-facing functionality. Patients can annotate the medication list for accuracy. To work, Medtastic needs a prescribing history, dispense medication history, allergies, problem lists, and diagnoses. So what happens here is we've got an innovative company. They've got a cool app. It needs access to a little bit of data from the healthcare system. But what happens? A company like this actually ends up dying on the vine often because in order to implement their technology, they need to do it one site at a time, one sale at a time, one CIO, security review, committees, et cetera, et cetera. And so a sale cycle may be well over a year. And when they're done, they've implemented in exactly one site. So the question is, how can we change this? One of the problems is that a hospital that's just spent $1.4 billion on its electronic health record system might say, look, we want to use our electronic health record system for that. Epic says they're coming out with better medication management down the line, so that's what we're going to wait for. So we think it's a mistake to try to run all processes through your electronic medical record. And in this piece in the New England Journal, what my colleague Zach Kohani and I point out is that in our consumer lives, we're enjoying tremendous opportunity in the kinds of technology that is available to delight us and change our lives, and that we use different technologies to achieve different goals. Now, some of the companies which are the most successful and productive companies and influential companies in the history of the planet would love to provide you with your full suite of software and provide all your innovation for you. So Microsoft would love to be providing you not only Microsoft Word and Windows, Office and Windows, but also they try to provide you your mobile platform, and they try to provide you internet browsing, and they're trying to provide you with search, the Bing search. But really, people use them for what they've been differentiated to do. Apple would love to provide you with a music sharing service and with cloud-based services. But probably many people are using Dropbox instead of the Apple cloud-based services, right? And Facebook would love to provide you with a whole bunch of apps. But really, they're primarily a social network. Google would like to provide you with a social network and with word processing. And to some extent, they are. But, when people are serious about social networking, they're going to Facebook. So the point is, these companies have not been able to provide the full range. And in the world of EHRs, we should not expect them to provide the full range of functionality either. The EHR companies also are not Google, Apple, Facebook, and Microsoft. They are not, these technology companies have not produced products at that level. And so it's really important that we allow innovation to occur in the periphery and to be used at the point of care. So without access to the point of care, everything is a one-off solution. So this is an example of something we've really done. At Boston Children's, this is a real implementation of pharmacogenomic triggering happening at the point of care on the Cerner electronic medical record. So here we're seeing that a patient is going to be prescribed 6-mercaptopurine, and we are checking, and we've actually run a TPMT enzyme test on them, genomic test on them, to see whether they have a variant that means they should have an adjusted dose of 6-MP. Now, there's two possibilities, and these are very frequent in the real world. One is that you've never had the testing done, in which case you need the testing before you prescribe the drug. The other is that the testing is done and you need the results. This took months of programming and back and forth work with our IT team to get this dialog box to show up. That means that while, yes, we are able to begin to adapt the electronic medical record system to enabling genomic medicine to happen at the point of care, it is going to be a long slog if this is the software that we have to use to get it done. So when the Obama administration was first taking office, I wrote a piece in the New England Journal called No Small Change for the Health Information Economy. And the idea here is that if they were going to spend $48 billion, and at the time we wrote this, it was only going to be $19 billion, but then as the stimulus package grew, more funds were added to this EMR adoption stuff through an act called the High-Tech Act. We said, if you're going to do this, shouldn't you make health IT look more like an iPhone than it does now? Now, we didn't mean the iPhone per se, although Apple thought we meant the iPhone, and we got to have some really cool conversations with some of the most visionary leaders at Apple out in Cupertino as a result. We didn't mean mobile specifically, although mobile is actually clearly a part of the smart platform vision. What we meant was that an app should be just in the same way that you can attach a new app to your iPhone, and that it has access to the core model inside your iPhone software, that the core data inside your iPhone software, that an EMR should be able to accept an app that was externally produced, present data to it in the same way every time, and actually run that app. We said that the key principle is not interoperability, but really substitutability, that apps should be substitutable with each other, so that therefore you should just as easily be able to add an app as delete it from your EMR, and that there should be something resembling an app store. This solves a couple of use cases. One is a company like Medtastic, the made-up company, can actually distribute their innovation across the whole healthcare system at once. The second opportunity is that the end user, the clinician, by the way, clinicians don't usually buy EMRs. Maybe small office practices do, but if you're a hospital-based clinician, your CFO, your chief financial officer, bought your EMR for you because it managed the financial workflows, and it may not do what you need to do. It will not have genomic data in it. It will not have the biomarkers you need to follow rare diseases, not even many common diseases. Even pediatrics itself has only recently been addressed by EMR vendors in terms of per-weight dosing, for example, and growth as an important aspect of clinical documentation and data. So what happens here is we said substitutability is the key. We want to service not only the innovators, but we want to enable also folks who are end users at getting customized functionality for them. So we managed this piece we wrote in the New England Journal, got a lot of attention at the time. And in fact, we held a meeting with over 100 invited participants. It was crashed by the White House, Anish Chopra, who was new in his role at the time, and Todd Park, new in his role as CTO of the HHS, and Anish Chopra was the United States' first Chief Technology Officer in essentially a cabinet-level position under Obama, reporting to the President. And he thought this was exactly aligned with what the technology-savvy Obama administration was trying to do across government, which is to actually have programming interfaces that allow apps models and modern interfaces to software and innovation. So we turned this into, we actually successfully competed for one of these grants under a program called SHARP, which was of the $48 billion, $60 million were being invested in 4 innovative research projects. So the question that we asked ourselves in this research project, which just coming to the end of its cycle, right, of that funding cycle now, is can electronic medical records behave like iPhones or Androids in that innovators readily create and widely distribute substitutable apps across thousands of installs? So this is the question we asked. And the thing you need is something called an API, an Application Programming Interface. The API presents data to the apps in the exact same way every time. That's the key. The app developer should have to know absolutely nothing about the underlying data model, which pharmacy information system you're using, which version of the microbiology tracking software do you need. The API doesn't need to address a lot of the data that's in electronic medical records that has to do with all kinds of QA, QC. We're not right now supporting apps, for example, that would need a data element that tells you the employee ID number of the laboratory tech that received the sample at a particular time in the laboratory. Those kinds of things are tracked in these very complicated workflows, probably not important for the kinds of apps that are clinician-facing that we're developing now. An example of why an API in a standard presentation is critical for the property of substitutability that we're trying to achieve is when the iPhone first came out, it used cell tower triangulation to measure position. That's when you actually figure out where you are compared to a couple of cell towers around you, and you draw those intersecting lines. It's not super accurate, but it works. When they moved to global positioning and satellite-based positioning technology, the app developers didn't need to know that. They didn't need to. Their software didn't break. They still wrote their API calls, something like get long, longitude and latitude, and they still got the XY coordinates and were able to put things on a map. What happened was the coordinates got more accurate, but the API abstracted out that change so that the apps continued to work. And so that one iPhone using cell tower triangulation and another iPhone using GPS could both run the same app and would provide XY coordinates to the app. This is the key. The medication list needs to be presented the same way at Partners Healthcare in Boston as it is at UCSF in California. And then the app will work. So the first thing we did was to eat our own dog food and design an app. We took a design challenge that was sponsored by Wired magazine. And Wired magazine said, what is the new laboratory information system of the future going to look like? You know, this is the laboratory information system of the present. A crumpled up piece of daisy wheel printer output stuffed into an envelope and mailed to the patient, and it's supposed to encourage individuals to now see that their cholesterol is out of whack and change their lifestyle, lose weight, eat healthier, all those things, go on statins, all that stuff. Turns out not to be a very interpretable or enticing way to display data either to clinicians or patients. One of the images that Wired printed was this, written by a guy named Dave McCandless, and he made this available under Creative Commons license, so we can use it here with proper attribution. There's the attribution right there on the left. And what we did was we took his image, and you can see this is a risk display that tells you about what kind of data, about how your data is interpreted. And you can see that it would be interactive so that your risk, that big percentage of 15% down there, will change depending on what your smoking status is, and you should be able to play with it and see how disease risk factor modification will change your risk of a myocardial infarction, for example, or cardiovascular disease. You could see this being used by a doctor at the point of care, by a patient, or by a doctor and a patient in a conversation with each other. What we did was we took that picture. That was just a picture made in a graphics program. It was not an application. It was not an app. It was a picture. Essentially could have been painted in watercolor. We took that picture, and in 1 week, our developer turned that into a smart app. Here is that smart app. This is an HTML5 app, and it's running in several systems. It's running on our Smart Reference Electronic Medical Record. It's running in our patient-facing electronic medical record called Indivo, which was the code base for Microsoft Health Vault and the model for Google Health, and actually was the actual dossier project that was run out by Walmart and AT&T. And it's running on an I2B2 system. This is a system that's been deployed across over 100 academic medical systems and uses electronic health record data outside the electronic medical record. So we achieved this property of not only substitutability but reusability. We were able to show that we could actually add and delete this app from these three systems, and also that we could reuse the same app running unmodified across these different systems because they all use the API. Anish Chopra encouraged us to take this to the next level and to have a contest, and we were one of the first healthcare-related contests on a new website called challenge.gov. We got 15 apps developed for $5,000 prize. These days, in contests, you need to offer a lot more than a $5,000 prize to get anyone's attention. But this is the app that won. Amazingly enough, this app was very similar to the app that we imagined this imaginary company, Medtastic, producing. This is by a company called Polyglot. And what they did was they took medication package inserts and translated them into user-friendly, patient-facing medication instructions in 14 different languages. And it took them all of 2 days to take their application, which is these thousands and thousands of patient medication sheets, nicely indexed, to be able to actually turn it into a smart app where these are automatically given to the patient on the basis of their medication list from the electronic medical record. It took them 2 days to turn this into an app that could be distributed to anywhere using the API. We went to our home base at Boston Children's Hospital. We went to the CIO and we said, we've got some money, can we spend it on the home front? So these guys are nephrologists and cardiologists at Boston Children's, were here waiting on the queue for 3 years with our electronic medical record vendor. They were waiting to get the following thing: blood pressures graphed for clinicians over time by age and adjusted for percentile. If you're not a pediatrician, I will tell you that a blood pressure in a 2-week-old has completely different norms than a blood pressure in a 2-month-old, than a 2-year-old, than a 12-year-old. You can't compare those blood pressures without adjusting for age. So the idea here is we need to adjust this thing for age. It's a task, quantitative task that a good 5th grader could do, but doctors are not as good as good 5th graders. Doctors cannot they do not have the time to sit there and plot out these things in the middle of a visit. As we know, doctors may only have 2 or 3 minutes with the patient. They cannot spend 5, 10, or 15 minutes making a nomogram like this and still get their job done. In 6 weeks in the user-centered design process, we created these apps for the clinicians. We plugged this right into the proprietary Cerner system using some APIs they had exposed. This is now pulled up in the middle of a proprietary EMR in patient context. It's used hundreds of times per week, and the users don't even know that this is a smart app. They just think it's the one sort of modern looking part of the Cerner system. Here's an app based on a paper we wrote that predicted medication adherence based on prescription fills, and we can predict your adherence a year from now based on your fill patterns. We turned this into an app to be used at the point of care. Here's another app based on what Polyglot did, that shows you your whole medication regimen for the day and how it should be taken. Here's an app that won design awards that we commissioned a high-end design firm in New York City called Fjord to actually reimagine an interactive growth chart. And this goes to show you that, that informatics does not have to be ugly. You can actually be very, very nice. This is an app that integrates external decision support with the electronic medical record. It shoots the immunization record up to a decision rules engine in this cloud, runs the CDC rules on it, and returns all back to the app a forecast of the immunizations you need next. Now, what this does is it allows the rules to exist in one place. So even if you had rules programmed into your Epic EMR, you'd be programming them at each site, and every time the CDC changed a rule, which is frequently, you would be updating the rules at hundreds or thousands of installs around the country. Here, the server's in this cloud, the rules are changed once. The app handles both the transmission to the cloud and the return. This is an app that does dense data display, customized to a particular use case. For example, a clinician caring for diabetes. We can reorganize the data or display different laboratory tests, biomarkers, depending on who's using it. This is an app that merges that we did in collaboration with Microsoft that merges your personal observations about diabetes from your glucometer with the electronic medical record data. This is a Microsoft Health Vault app. This is an app done with some of the consumer genomic companies where we take the consumer genomics data, the microarray data, mash it up with your electronic medical record data, and actually show you risk maps. This is the way to do genomic medicine going forward so that you can actually have a flexible interface, data mashups to the outside, incorporation of genomic data, graphically rich interpretations of the data for clinicians who do not understand genomics, and for patients who do not understand genomics. And so it gives you tremendous flexibility to use these data. This is an app that goes out to clinicaltrials.gov, but soon will be going out to actually a consortium-derived profile to help match individual patients to much-needed clinical trials automatically at the point of care, saving a clinician looking for a trial for their patient potentially hours or days of work. I'm going to start to wrap up. I will tell you the stage of the project now. We slaved away at this, interfacing the development of the API, the layering of the API onto individual systems, the development of apps, and having an interlaced process across all those three activities while trying to understand the ecosystem, evolving meaningful use criteria. And we found a very interesting thing happened just a couple months ago at HIMSS. HIMSS is the big electronic medical record HIT extravaganza every year. And we went down there knowing about our booth for SMART and another booth that we helped Cerner create because they became entranced by our success in the Boston Children's SMART app. But we actually found several other booths running our same apps on their systems that we didn't know about in advance, and that included the Harris Corporation, Intermountain, Brent James, Stan Huff, and those guys are actually using SMART in their both on their longitudinal medical record and as part of their new contract with Cerner. And Hewlett-Packard was running smart apps on a Vista system that they manage in their consulting business. There's a second way to use these data, and that is what we call the sidecar. The data can be, these apps can actually run in the middle of your EMR, but they can also run on a data warehouse next to the EMR, and this is a very important aspect of what we do. So while you can be Batman running them right in the main system that you've purchased, you may want to run these apps next to it on data extracted from the EMR, which is why we think it's okay also to be Robin in the sidecar. We've pulled together a consortium of members supporting our activities going forward, which includes Eli Lilly, it includes Medicare, it includes the largest for-profit health system in the country, Hospital Corporation of America, includes patient advocacy type organizations like AARP, content delivery organizations like the BMJ Group, governmental agencies beyond CMS, also in the UK and the Canadian Institutes of Health, as well as some other companies, visionaries like Clayton Christensen and Susanna Fox. Susanna actually just moved from Pew to Robert Wood Johnson this week. SMART enables us to bring big data from the doctor's office into to the point of care, not just the data collected in EMRs. This is a piece that we published in JAMA just a few weeks ago that shows all the different types of big data that we may want to concatenate for patients at the point of care, some of it patient permission, some of it population level. And I will show you for the last slide how in our clinical data research network, and I think you may be hearing more about this from Sean Murphy, or you have in a talk on I2B2, our clinical data research network, which is actually in the process of developing our interoperation procedures for working with patient-powered networks, and Genetic Alliance, of course, has a very important patient-powered network in that community. The way we're handling this is we have our 10 sites. They all have different electronic medical records. Smart Apps is actually a big piece of what we're doing, but we're taking those 10 electronic medical records and we're creating these sidecars using our analytic platform, I2B2, where the data are pulled out of the electronic medical record to where we can use the data in a manner that actually works for us. So it's a sidecar strategy. Then we actually can run queries across the data in all of these systems to identify patients of interest. For example, patients with a rare genetic disease. And we take the list that we have generated, we pass it back to each site. Each of the 10 sites handles all the identified information, and we use smart apps. There you can see the blood pressure app running in there. We actually use smart apps at the point of care to do all kinds of things, at the point of care or by the research coordinator, to either review the records, to do clinical trials matching, to contact patients, to conduct surveys, to do randomization, and then we return the data that we get from patient contact and other analyses back to the sidecar. So I'm going to hold it right there. I think I'm right at 30 minutes as promised, and I'm happy to answer questions, and I'll turn it back over to our distinguished moderator, Sharon.
Super. Thanks, Ken. That was really fabulous. A reminder to everybody who came in late, we will accept questions in the sidecar. Go to Webinar Control Panel under the question piece, so write your questions there. We have a couple teed up, so we probably have space for a couple more. So Ken, the first question that came up is, what about health information privacy? Apps are easy to access, especially by the service provider, for example, AT&T.
Yes. Well, so that's a very good question. Fortunately, fortunately, that concern doesn't apply to this project right now. The way you think about the data flows in this project it's exactly the same as the data flows in managing your own electronic medical record. So what we're talking about now is you're sitting in front of your electronic medical record, and instead of being stuck with whatever screen your vendor has provided you that shows, for example, probably the data formatted for the care of a typical internal medicine patient, probably not as good for the care of a cancer patient, a rare disease patient, or a pediatric patient. You download an app from the App Store and you run it right there in your EMR. The data and the data flows should have the same overall protection that you have for your EMR data. Now there's a caveat to that, which is that the data may, if the app is providing an external service, it may take some of those data and store them on the servers of the app company. This is an issue, but it's no different than the business associate agreement type of relationship between any healthcare system and any vendor that's providing the either services for billing or services for analytics or services for identifying high-cost patients. So those business relationships will have to be there as the data moves. From the perspective of a mobile phone carrier, they would not have access to any of these data. The data should be transmitted securely if the app was being used on a mobile device. The data should be encrypted in transport and not accessible to the mobile carrier. But the app company, if they're storing data on their own servers, would need the same kind of scrutiny that a CIO would provide if in any other business relationship. Making those, and ultimately, let's say it was a genetics app, we would see an organization like the Genetic Alliance wanting to say, you know, we've reviewed this, and this is a good app for you to use. This company actually handles privacy the right way, and you know, we're giving it our seal of approval. So we think there needs to be an ecosystem where there is actually a seal of approval. We've done a study that's under, I think will be published pretty soon, on privacy policies in the iTunes and Android stores, and they're pretty lousy. For healthcare data, we're going to need a much better privacy framework. So I think it's a very good question. The exact concern doesn't quite apply here, but it's actually close enough to real concerns that it allowed me to discuss something that I had glossed over. So thank you.
Yeah, very, very good. And I think these kinds of questions are important because it's both what is the reality and what is the perception. So thanks to the questioner. I should also say, too, that Ken is right. So Genetic Alliance is participating in PCORNet as one of the PPRN, patient-powered research networks. And we are able to hook up to I2B2, and so there will be interoperability between these things, which is really fabulous. The next question gets a little to that, and the question, Ken, is which standard names and codes, registries are you using for your measures data? This is essential for integration across EHRs for big data, correct?
Yeah, actually, it's funny. In order to give this talk, I actually just stepped out of a meeting we have on approaches to standardizing patient-reported outcomes within our network and potentially across work with PPRNs. You know, that is a larger question than I think applies to the SMART project alone, but I'd be happy to discuss that down the line. You know, there's the opportunity to network together around core measures so that we're using the same sort of quality of life score, for example, across multiple conditions and not different ones in different conditions will allow a lot of, will allow much more cross-disease work. And as we know, the taxonomy of diseases is such that two diseases in completely different specialties may actually have much more in common with each other genetically than two patients who supposedly have the same disease but with a completely underlying different mechanism. So we're very interested in that question, but I think that would require a talk in itself to answer.
Yeah, absolutely. And to the questioner, there are a number of really wonderful efforts. Some of them are coming right out of Harvard, looking at ontologies and nomenclatures, especially around rare diseases, since there are 7,000 conditions. Genetic Alliance has built crosswalks across all of the most common ones so that we are able to map to them. And I think where maybe the neophyte who comes to this field thinks we should all be using the same terms, the same languages, the same codes. I think those of us who have worked in this enough see that actually just being able to make sure they're interoperable is going probably to be the better way. We're never going to get everybody who uses HL7 to think SNOMED CT is the best thing since sliced bread. They are there for different reasons. These different nomenclature systems grew up in different systems. And so I think this approach that Ken has described is really a very effective way of working with a lot of data without worrying about those root issues as much. Okay, next question. This is fantastic and about time. Where do you see, and this flows right from what you just said, where do you see patient organizations fitting into this, especially patient registries?
Well, you know, there's the focus of the talk I just gave was really on the use of smart apps at the point of care. And I'll just mention that another focus is smart apps out to patients as well. The difference between smart apps and the other tens of thousands of apps in the iTunes stores are that these apps are designed to have access to the underlying electronic health record data and health system data. That's the focus here. We don't claim any kind of dominance over just all apps. This is one very specific slice. This is the interface between electronic health record data and the use of those data by doctors and patients. So smart apps do give you a way to actually go from those systems out to patients or clinicians who are using the data one patient at a time. In a registry effort, that may have implications, for example, for how you review the individual records in your registry. You could use the very same apps that an electronic medical record is using, the very same smart apps that an EMR is using. For example, let's say that you had a registry that included blood pressure measurements on kids over time. If you had the smart application programming interface on your registry, you'd be able to use our smart apps to review the records, and you'd see the blood pressures plotted over time in the same way. That might help you decide eligibility of a subject in your registry for a study, or it might help you understand a clinical outcome in an observational study that you're doing. So one thing to do is to run apps on the registry, and I'll mention that there are some very robust I2B2-based registry efforts, including PCORNet, which goes across 60 children's hospitals, and Improved Care Now, which both use I2B2, and both of them are looking to integrate smart apps into the registry infrastructure. Another piece would be in the patient contact piece, where if the patient contact were to include something connected closely to the health system data through something like I2B2 or directly to the EMR or some other source, you would be able to, for example, pre-populate fields or show patients their trajectories over time using electronic medical record data in a patient-facing app as well. So there are use cases. They're not in broad deployment yet, but that's the direction we're going. It's a great question.
Super. And I'll remind the audience we did a platform for engaging everyone responsibly peer webinar some time ago. Our registry system integrates with I2B2 as well, so I think there's opportunities there. And then the last question, unless another one appears before we conclude, and it's a similar one, Ken, so if you feel like you've answered it completely fine, it's a slightly different take that makes the observation that, yes, these are very provider-centric because we're talking about the point of care. Any uptake or ideas about patient-centered ones and what would be needed to move SMART into the consumer space?
What would it take to get SMART into the consumer space?
Yeah.
So, you know, it really is, this consumer space has been a very tough nut to crack for a long time. And there are now more companies than ever looking at what is the consumer space in healthcare. As you know, Apple made a foray into the consumer space recently, and they did a very interesting thing, which is to say, and this relates to what I was talking about earlier, they're inside the core data model of the iPhone, in addition to having data types like your longitude and your latitude as a core resource for any app that's going to be on the iPhone platform. Now the very data that you've collected in your Fitbit and other mostly sort of quantified self type devices will be available directly to apps so that they can go right into the core data model of the iPhone and get those data back out in a standardized format. So the Apple answer to apps in the consumer space is to essentially marshal this new data source of consumer quantified self data into iPhone apps. A similar opportunity would be to say there's certain health system data that we want to get in there, and those can be used, those can be presented across a SMART API, either in something like a mobile device like an iPhone using the native apps, or something like web apps which will run platform independent on desktops, laptops, or any mobile device, HTML5 web apps. So the opportunity there is, again, SMART is focused not on all apps, but specifically on the apps that are driving the interface between the underlying electronic medical record data and the apps that use those data. So one way to do it would be to have a product that had access to electronic medical record data either directly or through some kind of extraction process and displays those data to the consumer across the SMART API using SMART apps. And there are actually a bunch of companies that are looking at this very workflow, and our mailing lists are very active there.
Super, thanks. And another question, so talk about the business model for making sure that this is sustainable and that it's accessible and that it takes off.
So that's something very much important. That's extremely important. We've gotten actually real investment from these SMART Advisory Committee members because they believe there really is a business model here. There are key aspects to this that make healthcare much less expensive to deliver when you have the opportunity to flexibly change the interface, the workflows, the data displays. So for actually not a very large investment in making your information technology able to run smart apps, and we demonstrated over the last 4 years in our ONC-funded project again and again that it is relatively trivial to layer the SMART API onto even as complex a piece of existing information technology as the Cerner system, which is very complex, that we can actually layer that on cost efficiently. Once you've done that and agreed upon a standard, you get tremendous economies of scale in terms of the ability to distribute innovations widely and the ability to change the interface between the data and the way you're using those data. So an example, the ability to implement clinical practice guidelines by having the right workflow or decision support that nudges people towards less expensive and more efficacious decisions. The ability to begin to bring genomic data to the point of care in a scalable and cost-efficient way. The technology that we're talking about is really essentially just a layer of an API that presents data in a standardized format, has a way for apps to authenticate themselves, and manages the security in a way that is not an expensive addition to the healthcare system. The key is to get that standardized so that we can have the economy of scale from having the ideal that an app built once can run anywhere.
Super. Well, thanks very much, Ken. That was really fabulous. Thanks to the questioners, because I think those were very meaty questions. There were a few comments as you were going through that this was one of our more technical webinars, and we appreciate that some of these do seem somewhat dense in terms of the technical nature of the material, but I think you made it very accessible as you went through the description. So thank you very, very much.
All right. Thank you, everybody.
Great. And I'll remind our audience that we have this webinar as part of a series that you can look at the archive website and look at the recording of this webinar and the slides, including the question and answer period after about a week after the webinar, so about a week from now. Our next webinar is Tuesday, August 5th at noon. It's called TransSmart, which has nothing to do with this smart, well, although there are certainly interconnectivity, but I won't go into that because it could make us even more confused. That webinar will take place again on Tuesday, August 5th at noon. We have lots of thank yous erupting, Ken, on the little sideboard here, and so people really appreciate what you had to offer. Thank you again, and thank you to everyone. Have a good morning or good afternoon wherever you are.
Thank you.
Bye-bye.